the JAMA Network.
My name is David Ash. I'm director of the Center for Healthcare Innovation at the University of Pennsylvania, where I'm a professor at the Perelman School of Medicine and the Wharton School, and I see patients at the Philadelphia VA Medical Center.
I'm Kevin Volp. I'm the director of the Center for Health Incentives and Behavioral Economics. I am also a professor at the School of Medicine and the Wharton School of the University of Pennsylvania, and a staff physician at the Philadelphia Veterans Affairs Medical Center.
So this project addresses a critically important question. We know from large clinical trials that if you're a patient at high risk of cardiovascular disease, at high risk of having a heart attack, your risk can be substantially lowered if you take medicines to reduce your cholesterol, medicines like statins. And yet it turns out that many Americans never take those medicines, or when they start them, they stop them very soon after beginning them. That was the problem we were trying to fix.
We studied the question of whether patient incentives to doctors, or a combination of the two, are most effective in reducing LDL cholesterol among patients at high cardiac risk. To examine this question, we studied 1,503 patients at 3 different health systems: the Geisinger Health System, Harvard Vanguard Medical Associates, and the University of Pennsylvania Health System. And we studied among those 1,503 patients and 340 doctors whether patient incentives, provider incentives, or shared incentives between patients and providers were most effective in improving LDL cholesterol over a 12-month period. Each participant was followed for 12 months, and then we did post-intervention follow-ups at 15 months.
The interesting thing that we found was that the system of shared incentives, in which the patient and the physician each has a financial incentive to improve their cholesterol, worked the best. We found that when patients alone received incentives, their medication adherence went up, but it wasn't enough to make a substantial improvement in their LDL cholesterol. When physicians alone were incentivized, when they received a financial incentive, the amount of treatment that they gave to patients went up, but that alone wasn't enough to make a difference. Only when we had the two together, the patient incentives and the physician incentives, did we see a statistically significant reduction in LDL cholesterol in this patient population.
Yeah, I think the fact that the shared incentive was most effective is really highlighted by several of the numbers that we describe in the paper. We see higher rates of intensification of therapy. We had about half of the patients who enrolled in this study who were not on statins at baseline. We found that the rate at which people started statins, or at which their doctors intensified therapy, was highest in the shared incentive group, next highest in the provider incentive group, with little movement in either the patient incentive or control group. And then on the other hand, on the medication adherence side, we found the biggest improvement in the shared incentive group, the second biggest improvement in the patient incentive group, and then very little movement on either the provider incentive group or the control group. So it really seems that for conditions like this, where both provider and patient engagement are important, that this type of shared incentive is really important to trying to get both providers and patients engaged in lowering risk.
You know, there's a considerable amount of interest in the use of financial incentives to improve healthcare quality, not just in the US, but around the world. And that may work in many, many contexts. But what we found in this study was that providing financial incentives to physicians alone didn't work. Again, that may work in other contexts. Here, we found that the incentives had to be shared between patients and physicians for them to be truly effective. Now, in some sense, that isn't too surprising, right? Doctors and patients need to work together towards important clinical goals. So we shouldn't be too surprised that the combination, the sharing of incentives, is what's required to get people to the finish line.
Provider incentives are used by many healthcare organizations around the world. And what we find in this study is that layering provider incentives to improve quality on top of fee-for-service reimbursement does not work very well. This may seem counterintuitive, but it really reflects the fact that the predominant incentive that doctors in these systems faced was still related to providing fee-for-service and really focusing on the volume of services they provided. In these types of settings where patient engagement is critically important to improving health metrics, it seems important to think about shared incentive programs that really bring both providers and patients into the mix together. This is the first study to have ever examined the question of shared incentives for providers and patients, and it provides proof of concept that these types of shared incentive programs might be an important way for us collectively to improve health of populations going forward. But it's going to be really important to think about and to test ways to improve on this program and really design increasingly more effective, more cost-effective shared incentive programs. We can try to improve the way we do provider incentives. A lot of that relates to shifting the way we pay doctors in general and focusing on making that as effective as possible. We can also try to improve on the way we do patient incentives. But in this context, probably working on the dimension of making the shared incentive program more effective is going to be the highest yield approach.
You know, I think that this study demonstrates that shared incentives can work in achieving important patient goals. I think there are so many other things that we can do to try to think about improving medication adherence and improving clinical outcomes for patients. So, for example, social support, which wasn't tested in this trial, might be very important to study in later trials. So much of medication taking is private. It happens in your bathroom, it happens in the kitchen. It's not that it's such a secret, it's just that no one else sees you doing it. It's quite possible that if we made medication adherence more out in the open, so you did it in some sense more publicly, adherence might improve. As we all know, behaviors are substantially better when people know that someone else is watching.